Great. So we have two questions coming in from online. The first is the ministry using its own population estimates, and is it considering the significant underreporting in the census of Indigenous populations in some areas?
I'm not sure what the attributed population that is going to be provided to application based on existing utilization and referral patterns. So I don't know that the actual census counts appear there. What appears there are, if you are rostered to a primary care physician, then you would be attributed to that population. If you are not rostered, but you seek care from a primary care physician, if you receive them multiple, you've been attributed to that group. And there's about 2% of the Ontario population that doesn't fall into either of those categories, and so there's a slightly more complex calculation. With Indigenous peoples in particular, I'm not sure how, depending on where they receive primary care, they would be treated in that attribution model, but that's an excellent question to write to the ministry about. They have a data team that would be able to provide an immediate response. So I'm not involved in those data calculations, but I know that an email into that group would elicit a very quick response.
Great. The second question is, when looking at a specialty hospital, is it looking at partnering with hospitals or a specialty tertiary care hospital?
I think that, I'm not sure that I got the question entirely, but I think one thing that we all need to be aware of is that when you think about building a team that covers the full continuum of care, when you get to acute hospitals, some of those hospitals play both the role of a local community hospital, in which case it could be that they are entirely captured by that Ontario Health Team. But many hospitals also play a regional role, and some play a provincial. So an example of the provincial role might be, let's say, Waypoint, which is a mental health facility, has a provincial forensic psychiatry program that serves the entire province. I think that that is something that is being worked out and will be worked out in the years to come, how those regional and provincial assets intersect with Ontario Health Teams. There was a slide earlier where I said the expectation is that at maturity, Ontario Health Teams would cover the full continuum of care, except for the most highly specialized services. So those will always remain separate with the exact definition to be determined. But I think between now and maturity, there are lots of unanswered questions about that gray space between the types of services that get access most of the time versus those ones that might be sufficiently specialized that there's some regional dimensions. So that space, I think, will stay gray, and the ministry is going to be looking for advice from many different corners about how to deal with that. And there was one other point that I was going to make, which has to do with the innovative models. So I mentioned that there are 31 teams going to full application, 41 that are in development, a number that are in discovery. There's also a small number of innovation models, and those are often groups that provide that more regional and provincial focus. So 3 of them are in the mental health and substance use space, for example. One is the Centre for Addiction and Mental Health in Toronto that has the potential to provide a regional, if not a provincial focus in the area that they're focused on. 2 of the other examples are children's hospitals that provide a regional, sometimes a provincial focus. So the innovative models is one of the ways that the ministry is trying to understand how do we have these regional and provincial assets intersect with these fundamentally local assets. So you don't need to solve all of this now. The big focus is what makes sense for your team with these services that are more inherently local. And there will be many, many future conversations about the regional and provincial assets. Are you going to add something?
I wasn't, but I would just say that when you're thinking about care pathways, you might want to think about at what point do you need to step people up to those tertiary or more specialized services. So you might still be identifying the need for them, but you're not planning for them locally.
Just a quick question on, being a very small applicant. We got put in discovery. The letter did highlight a few points of what they needed us to work on. One of them was mental health. But there's 2 questions to this. A, as a smaller team who does a lot of chronic and episodic care with patients from a mobile health perspective, and also from a home care perspective, we do a lot of private, but we do a lot of chronic care, for the high needs patients from hospitals in Toronto. how do we start engaging these hospitals from a larger scale? Because that's the part that to me, it seems missing out on. And I guess my second question was around A, was partnering with the hospitals, and B was, I'll come back to it if I remember. Sorry, just lost my train of thought. But if you can address that, that'd be great.
For sure. So, I guess, so with the hospitals, so keep in mind that, teams are going to have multiple parts. One, or vast majority would. And the teams that are at this critical juncture of going to full application are really focused specifically on meeting this 9th of October. So if you feel that the solutions you're bringing to the table connect very directly to helping them meet that deadline successfully, then the best thing to do would be to then contact the focal points for those teams. Chances are, for most people in your position, now is not the right time. Wait until they get through the application process. One of the things that came up earlier in the day was that wouldn't it be fantastic if once the teams have submitted their full application, if they were willing to share their priority population, so the areas that they're focusing on, that would allow folks like you and many others to say, oh, you're working in the mental health and substance use space. We have some ideas for how you can better meet the needs of people living with those conditions, and then start to make those connections. And then there are the innovative models as well that are using kind of that cross-cutting approach. So if I were you, I would be kind of tactical about when to approach people. My sense is teams in full development, unless you're going to be able to help them with particular parts of the application, probably don't have to. But after that, there's going to be many opportunities. And I'm talking right now about Ontario Health Teams, but then there are also these other conversations that are happening at the provincial level with the Centre of Excellence in Mental Health and Addictions, where they're going to be thinking through province-wide approaches. So there's other ways in for you, and I think my general advice is keep an eye on the broader ecosystem and then time your approach very specifically to their needs at that particular time. Heather, you might have some additional comments on this. Want to add anything?
No, I think the teams that have the deadline of October 9th are, as John's mentioning, probably fairly focused and slightly overwhelmed with the tasks that they need to get done. The teams in development might have a little bit more runway. So if you wanted to start somewhere, maybe there are some teams in development that might be a place to approach, because they have the ability to integrate you and your organizations into their planning.
Would you say, do you mind if I just back by, is the types of solutions that you're bringing to the table, are they inherently local, or could you imagine a model where they end up being conceived of as regional or provincial assets that individual teams then use locally?
We've got if you talk about the in-scope services that we provide, we've covered everything off. We've checked almost every box except for hospital engagement and addiction and mental health. We've checked everything else off. We've had a 1.5 years of proof of concept of the ecosystem that we've created privately. Like that's partially OHIP, partially private pay.
Yeah.
We took that model and said, okay, this is what the system needs after years of studying it, right, at the leadership level. We said, this is what the system needs. This came out. So we said, well, why don't we bring this to the table? We have an opportunity to apply that model, right?
So are you
everything. We're providing primary care, digital health, telehealth. We're providing sort of everything you can think of except for the hospital engagement part and the mental health part of it. We do a lot of referrals to the different areas, obviously, but we've covered that off pretty much in a broader sense.
okay?
Yeah.
I'm entirely right. Follow up.
Sure.
One thing is that if you are touching this week or relatively soon, if not this week, it's what's called the Digital Health Playbook. Describe their conception of where we need to be from that perspective. So that will be very oriented advice if still is a component of what it is that you're bringing to the being able to speak to the language captured in the document will be very important.
Would it help? Because we've done about 2 years of research in 9 different states in the U.S. Because some of us have trained in the States. Would that help? It's based on sort of not just what's been done, what the government wants here, but we've also done a lot of research, about 2 years worth.
I think that slides was the importance of evidence. So I think
Right.
people are increasingly going to be saying, what evidence do you have that this is effective and cost-effective to reach our priority? So if you have robust evidence understanding what you're putting forward, then that absolutely should be front and center in your description.
I just find in the initial the readiness document, I just didn't think we had enough space to put everything down.
Yeah, for
So
sure.
this is where I'm
That's
coming back and saying, is there an opportunity to go back to like a RISE and say, would you guys help us evaluate our model possibly? Let's have a brief look at it, meet with you guys down the road and say, hey, this is wow, or this is what you need to work on as well. 'Cause
And you know, one of the reasons why on the central program of support slide, Aaron mentioned the importance of the central coordination is that right now the ministry has a few partners in it, of which RISE is one, but they plan to, as Karen said, add partners over time. One of the things that has been under discussion is whether there would be a group that would specifically focus on digital health evaluation, so being able to speak the language of where the ministry is hoping we're going to get in that space, but also speak the language of folks with solutions like you might bring to the table to better understand when there's a connection, and if the evaluations that have been done aren't entirely convincing for our context, to help you think through what would be required to get to the next stage. So I would encourage you to keep an eye on that central program of supports, and you could submit a question now to see if any decisions have been made, but check in a few weeks, a few months, because it could be that there is an element of the central program that can better meet your needs on the digital side. Any other questions online? So
Carrie,
let's go to some online questions.
so one question that came in online was, do we know if the ministry is looking at a partner being a part of more than one OHT?
So again, I can't answer policy questions, but I can just tell you that we've heard from many people that there are partners that are on multiple applications. So there are groups in this province that their delivery mechanism is very distributed, and they have groups in almost every community, and you'll see that organization represented on many of the planning teams. So it's absolutely appropriate. I think where the tension arises is where we get to that issue about an economy of scale, because your solutions that you're bringing to the table, or your knowledge of populations or whatever, is more regional and provincial. So that to sit at every table might not be possible. You as an organization might not have. That's an area that we're hoping through RISE and other parts of the central we can help people navigate, to think about when is it important for you to be there at all the key meetings, versus are there ways that we can get teams working together and bring you in ways that you can contribute to the thinking in a more efficient way. And then there's going to be times where the preferred delivery route is actually regional or provincial, and the teams need to be able to intersect with you, but it doesn't make sense to reinvent the wheel in every single community. So that's something that we've learned a lot about today that we need to be actively thinking about. Other questions from folks in the room? Questions? So we'll just give you a few more minutes. I always say to students, we're in the lecture hall, say it again, comfortable with silence, so I'll wait you out. See if you have any questions. Otherwise, we'll wrap up a WebEx session and always speak to you individually. If you're here in person, it's always better to ask others can hear, because it's similar. Questions, comments, especially if you're involved in a team in discovery.